All right, let's dive into the world of antimicrobials. We're talking about the heavy-duty drugs we rely on to fight off some of the toughest microscopic invaders out there. But here's the catch. These drugs can be pretty tough on our patients too. So today, we're going to break down 3 major classes, creating a really clear, practical guide for using them safely and effectively. Let's get right into it. In the world of infectious disease, it's like we're up against this whole gallery of microscopic villains. Today, we're zeroing in on 3 of the big ones. First, you've got this slow-growing, really tough kind of armor-plated bacteria that causes tuberculosis. Then there's the opportunistic fungus, the one that can just take over when someone's immune system is down. And finally, the ultimate cellular hijacker, the virus, which literally turns our own bodies into factories to make more of itself.
And that really gets to the heart of the matter for any clinician, right? It's not just about killing the bug. It's a full-on strategy game. How do you pick the perfect weapon, figure out its side effects before they happen, and most importantly, keep your patients safe through it all? That's the challenge we're tackling today.
Okay, so let's start with our first enemy, tuberculosis. Now, treating TB isn't some quick hit. It's more like a long, drawn-out siege. We're talking months of therapy against a bacterium that is incredibly resilient. This is a real battle of endurance, and picking the right combination of weapons from day one is absolutely critical.
So here's our battle plan, laid out really nicely. Think of it like this. We have 2 tiers of drugs. The first-line agents, that's your isoniazid and rifampin, they're our go-to squad. They're the most effective and generally the safest. The standard treatment almost always uses a cocktail of these drugs because hitting the bacteria from multiple angles at once helps prevent it from figuring us out and becoming resistant. But if that TB is already drug-resistant, that's when we have to call in the second-line drugs. These are like our special forces, not as broadly effective, and they come with a much higher risk of side effects. But you need them when the main plan isn't working.
Knowing the potential collateral damage of each drug is just crucial. And you probably notice a theme here, right? 3 of the 4 first-line drugs can cause hepatotoxicity. That's liver damage. So we've got to be watching those liver function tests, or LFTs, really closely. For isoniazid, also known as INH, we also have to watch for peripheral neuropathy, that pins and needles feeling in the hands and feet. The good news is we can usually prevent that just by giving some vitamin B6. With ethambutol, the concern is vision, so regular eye exams are a must. And then there's rifampin, which has this very memorable but totally harmless side effect. It can turn tears, sweat, and urine a kind of red-orange color. You absolutely have to give your patients a heads up about this so they don't freak out.
Okay, let's pivot now to our second enemy, fungi. Now, fungal cells are a different beast entirely. They've got this unique, really tough cell wall and membrane. So our strategy has to be different too. We need drugs that are designed specifically to breach those defenses.
So, the antifungal arsenal is split into 4 main groups, and they each attack in a different way. You've got the polyenes, which basically punch holes in the fungal cell membrane. Then the azoles, which stop the fungus from building that membrane in the first place. The antimetabolites mess with the fungus's DNA and RNA, and the echinocandins go after the cell wall. For today, though, we're really going to focus on the heavy hitters in that first group, the polyenes.
So, polyenes, like the famous amphotericin B, work by literally punching holes directly into the fungal cell membrane. They create these little channels that cause all the cell's important stuff, especially electrolytes like potassium, to just leak right out. And that, as you can imagine, kills the fungus. Because this is such a powerful and direct way to attack, these drugs are saved for the absolute worst-case scenarios, those severe, life-threatening systemic fungal infections.
If you think of the TB drugs as a coordinated strategic strike, then amphotericin B is a sledgehammer. No question. It is incredibly powerful and effective when you're dealing with a serious, widespread fungal invasion. But just like a sledgehammer, all that power comes with a huge risk of causing some serious collateral damage to the patient.
And this right here shows you exactly what we mean by collateral damage. Amphotericin B is notoriously toxic. The biggest concern, the one everyone watches for, is nephrotoxicity, kidney damage. We track that by watching blood tests like BUN and creatinine. It also causes really severe electrolyte imbalances, especially low potassium and magnesium. On top of that, patients often get infusion reactions like fever and chills, and it can even suppress bone marrow function. This is absolutely a drug that requires constant, vigilant monitoring of kidney function, electrolytes, and blood counts.
Okay, on to our third and final enemy, the virus. Viruses are the ultimate parasites. They can't do anything on their own. They have to hijack our cells and use our own machinery to make copies of themselves. So our antiviral drugs are designed to be saboteurs. They get inside and just throw a wrench in that whole replication process.
And we've got a whole range of targets. For the flu, we use drugs like oseltamivir, but here's the kicker. They have to be started within 48 hours of symptoms, or they're not really effective. For herpes viruses, drugs like aciclovir work by messing with viral DNA, stopping it from copying itself. For really serious infections like cytomegalovirus or CMV, we need heavy-duty drugs like ganciclovir, which work well but carry a big risk of bone marrow suppression. And then for chronic infections like hepatitis B and C, we have a whole variety of agents that work to just keep the virus suppressed long-term to prevent liver damage.
So we've looked at 3 different enemies and 3 completely different arsenals of drugs. Now, let's pull it all together. Let's build a practical safety playbook that helps you remember the most important thing to watch for with each of these classes.
Okay, this slide right here, this is the key takeaway for this entire explainer. This is your clinical cheat sheet. It's simple. When you think anti-tuberculars, think liver. You're watching those LFTs. When you think potent antifungals like amphotericin B, think kidneys. You're monitoring BUN and creatinine. And for many of those heavy-duty antivirals, especially for CMV or herpes, think bone marrow. You're keeping a close eye on the complete blood count. Liver, kidneys, bone marrow. If you can lock in that association for each drug class, you've built a powerful mental shortcut for patient safety.
And this is exactly how we put that knowledge into action. It's a constant, active process. First, you recognize the cues. You look at the patient's history, their baseline labs. Then you generate solutions. You start planning ahead for what you'll need to monitor, what you need to teach the patient. Then you take action. You give the drugs correctly, you remember to give B6 with INH. And finally, you evaluate the outcomes. You're always checking, is the patient getting better? Are there any signs of those side effects we talked about? This turns facts you memorized into a real dynamic safety process.
You know, when you boil it all down, it really comes back to this one simple principle. Every single decision you make, every lab you check, every bit of patient education, it's all aimed at finding this delicate balance. Our job is to wield these incredibly powerful tools to wipe out disease, while at the same time protecting the patient from the very real risks that come with them.
And that leaves us with a really important question to think about. Our enemies, from multi-drug resistant TB to new resistant fungal strains, they're evolving. They're getting smarter. And that just highlights how urgent the need is for new strategies, new drugs, and honestly, an unwavering commitment to using the tools we have now as perfectly as we can, to make sure our playbooks are still going to be effective for the battles that are just around the corner.